quorum. We've got a pretty hefty agenda.
All right.
While we're giving people another minute or so to join electronically, I just wanted to give a couple housekeeping items. Just a reminder that the meeting is being recorded. Anything said or projected during this meeting will be part of that recording. If you are joining by phone only, please press star mute to unmute yourself. Again, a reminder, if you're not speaking, if you could please keep either your phone or computer on mute. And if you're joining electronically, you can use the mute button to mute or unmute yourself. We have the chat feature at the bottom, and you can also raise your hand if there are a number of people that are speaking, you would like to speak up as well. We are going to go ahead and call to order. It is 12:01. Shelley, if you can please start with roll call.
Thank you. The unmuting is *6 to the test. All right, roll call. Amber Rice.
Present.
Dan Spate. Franco Castromarin. Frank Walter.
Present.
Gail Bradley.
Present.
Steve Mudbanker.
Present.
Jason Johnson.
Here.
Josh Gaither.
Here.
Julie Augenstein. Kevin Foster. Michelle Preston.
Present.
Thank you. We have 7. We have quorum.
All right, thank you very much, Shelley. Just a reminder, if you are not speaking and joining by phone, if you could please keep your phone on mute. We are getting quite a bit of background noise. I will start muting people here in just a second if necessary. Thank you. Just a reminder for the attendance report, this is in your packet. If you missed 2 or more consecutive meetings, you will get asked by the Bureau if you would like to continue your participation on the meeting and as part of the Medical Direction Commission. For vacancies, we have 1 vacancy for a physician who specializes in severe acute head injury treatment or spinal cord care and who has demonstrated interest or expertise in emergency medical services. We have a busy agenda, so I will briefly touch on the next 2 items. Just a reminder, we are still wanting to advertise the naloxone leave behind program. We recognize that over the last 2 years, we have seen an increase in the opioid overdoses throughout the state and nationally. In your agenda packet, there is a link to the naloxone section of our website, which has resources if you would like to initiate a naloxone leave behind program in your jurisdiction or region. Next on the agenda is item D for an update. The National Association of EMS Officials, NASEMSO, is getting their final input from stakeholders and the public regarding the model EMS clinical guidelines. Just a reminder, the last update we did utilize to update the TTTGs. These should be finalized hopefully in the next couple months, and we will start that process of updating our Arizona guidelines once again. If you have any comments you would like to make to NASEMSO on the draft version, the link to that public comment survey is in your agenda packet as well. I will turn over next to Chief Garcia for the Bureau Chief report. Chief Garcia.
All right, good afternoon, Dr. Bradley and Commission members. I'd like to share some general updates on the administrative front. The Bureau and 4 regional EMS councils recognize the continued stress put on our frontline workers. Together, the Bureau and regional councils have developed a workforce needs and interest assessment. Each region will be promoting the survey, and we ask that the statutory committees also encourage participation so we can gain more insight into some of our workforce needs in Arizona. Please take a few minutes to complete the confidential survey, and don't forget to thank our frontline workers. We don't have any updates to share today on air or ground ambulance rules at this time. However, the Article 9 work group will convene again in February to provide additional feedback on CON rules, including recommendations on response times. As you all know, EMCT scope of practice and drug tables were recently updated in August 2021, and we thank MDC for weighing in today and reviewing some additional scope of practice considerations for EMCTs. Quickly, regarding current trends we are observing, we continue to see a high volume of positive COVID cases in our state. Although hospitalizations are not increasing at the same rate as Omicron cases, we know that EDs are saturated and the number of staffed beds in hospitals remain extremely limited. We recognize that some facilities have activated crisis standards of care based on staffing levels. And as we navigate ongoing challenges that span the healthcare and EMS system, we will definitely be leaning on the statutory committees to help provide additional recommendations on strategies for EMS surge. We will use these meetings to focus on bright spots and highlight best practices when possible. And we remain committed to providing timely updates to all of our EMS and trauma providers through our regional councils, as well as our Gov Delivery listserv. If you've not done so already, please subscribe to the Gov Delivery updates for the Bureau of EMS and Trauma System. Again, Gov Delivery will remain our primary method of communication moving forward. I'll quickly welcome some of our new staff members. The Bureau has been quite busy focusing on recruitment and hiring. Our newest hires are Antonia Gerard, who joins us as our rate analyst for the CON and rates program. Thomas P.J. McKay is our new training program manager. And Cody Curl is our new EMS Workforce Initiatives Coordinator working on a new CDC grant that we've received. Welcome to all of our staff. We look forward to introducing you to the Commission and the other statutory committees. Back to you, Dr. Bradley.
Thank you very much. We have been bringing back to each of these meetings an update on opioid and out-of-hospital cardiac arrest data. Vatsal and her team put quite a bit of work into updating those numbers. We are still seeing an increase in those numbers, but Vatsal wanted to do a little bit deeper dive into the data to check some accuracy. So we will bring that data back to this group in May at our next meeting. A quick update regarding the SHARE program. Many of you have been part of the SHARE program as it developed within Arizona over 15 years ago. As part of the kind of organization and kind of cleaning up some of the processes, Julia Vinton has been working diligently with the hospitals to request documentation that they are still meeting and maintaining cardiac receiving or referral center status. Part of the rationale for that is if we are going to ask EMS providers to bypass a facility to go to a cardiac receiving center, we want to ensure that that facility has the capabilities available. So she has been working really hard to collect that data. Again, we appreciate all the support. If you really look at Arizona, we are really leaders nationally, and many people look at the system that was developed here in Arizona with support of MDC as really increasing survival for out-of-hospital cardiac arrest. So we will continue with the work on the SHARE program moving forward. And next up for Travis for EMCT certification and educational resources update.
Good afternoon. This is Cody Curl. Travis had to attend something else, so I'm just going to give his update for today. So for EMCT certification, as many of you may know already or be aware of from previous committee meetings, over the next few years, the Bureau will be heavily focusing on IT improvements related to the EMS portal, just to start providing additional value to our stakeholders, end users, and internal staff. These improvements will consist of modernization efforts to improve the look and feel of the portal, allow the end user to access and submit various applications from a smartphone, tablet, or web browser, develop a hub where Bureau announcements, education, training materials, CE courses, and wellness resources will be located, create a fully online CON application to eliminate the need to submit paper applications, develop a user-friendly online rates application, and so much more. The Bureau's vision for the EMS portal is to create a sort of one-stop shop for all tasks, duties, applications, etc. that relate to the EMS and trauma. For internal users, the improved EMS portal will provide real-time data and reports at the click of a button, have customizable dashboard that displays important program metrics and processing timeframes that can be tailored to the specific user. This improved portal will allow our team to be more agile, efficient, organized, and productive, which will have wide-ranging positive impacts on our community. The portal will be a place where stakeholders and internal and external users alike will want to access it often due to the value it will provide to your everyday work and personal lives. Our first focus is going to be improving the EMCT certification process. And we are pleased to report that since the project kicked off a few months ago, so much project progress has been made to the EMCT certification process for our external users. At the moment, we're currently in the late stages of the development phase and approaching the time where we will be able to test the improvements. If you're interested in testing our improved EMCT certification process, please reach out to Travis. His email is travis.connors, that's CONNORS, at azdhs.gov. We'd love any feedback and involvement from our stakeholders to ensure a successful implementation that benefits everyone. In regard to education resources, our Bureau is excited to announce that we are inching closer to implementing our improved EMS education webpage. The improved webpage will provide an enhanced visual appearance, a reorganization of the information and resources provided on the webpage so that our end users can find relevant and specific information in a more efficient manner. A few aspects of the webpage that we focused heavily on are continuing education and the upcoming course schedule. The continuing education section is already live. It's going to provide a lot more detailed and comprehensive list of upcoming CE courses that are free or low cost, with the goal of providing additional and easy access to resources to improve workforce trends. Additionally, the upcoming course schedule, which is not yet implemented, but will provide an end user with a calendar that displays all of the upcoming courses and can be filtered by the type of course an individual is interested in, as well as the specific data needed to enroll. Rather than having the community or end user search through a busy sort of PDF document to find a course that fits their need, you'll just be easily able to search through a Google Calendar that is updated on a regular basis. For any questions about that update, please contact myself at cody.curl@azdhs.gov. Thank you, guys.
Thank you so much, Cody. All right. Next up on the agenda, I just wanted to make sure that we mentioned that the Education Committee in November had produced and approved a training curriculum on COVID-19 trends, medical decision-making capacity, and patient refusals. This is an excellent presentation that really looks at some of the national and statewide trends and how COVID has affected patient acuity and refusals in the out-of-hospital setting. Dr. Rice very kindly recorded this as well in a video format, which is linked on our website for ease of download. We did get some feedback that the way ADHS uploaded it in the YouTube format may not work with your training software. If you need us to send that to you in a different version, please let us know and we can certainly do so. Next, we will move to the standing committee reports. First on the agenda is Dr. Augenstein for TEPI. I do not believe she is on the meeting today. Have you seen her join us, Shelley?
I concur. I have not seen her join yet. We may need to skip that one.
I do not see her. I think if you wanted to give maybe a 1 to 2 line summary, if you had it available, Shelley, otherwise we can skip that for today.
You want to move on to the next one while I pull up a draft minute?
Sure, thank you. Next up on the agenda, Dr. Gaither for Education Standing Committee update.
Thank you, Dr. Bradley. This will be a very brief update as I do not have the minutes from those meetings to reference. I will say at the Education Standing Committee, there are multiple ongoing education initiatives that the committee is focusing on. And I think Dr. Rice can assist anyone with questions on the ongoing initiatives. Any member that has questions about those can email Amber separately. The update from Protocols, Medications, and Devices Standing Committee. The committee reviewed and approved several items which are on the agenda later today and will be discussed in detail on the agenda later. So I don't think we need to provide any more reports from that standing committee.
All right. Excellent. Thank you, Josh. Next up, Adam for PACES update.
Hi there. So for PACES, we recently had a vacancy in our council member. We're looking for a nurse with pediatric experience to step in and help us out. We're very close to publishing a Narcan training tool that needs to go through the Education Committee, I believe. We have a couple of different work groups going on, and one is a behavioral health work group. So last meeting we compiled and reviewed resources for that work group, and we are also looking for someone to help us out with a behavioral health background in that work group. If you know anybody that's interested, please email me. And lastly, we approved the creation of a new work group that will attempt to identify training gap topics, which is still open for volunteers as well. Our next meeting is on March 17th. Thank you.
All right, thank you, Adam. Next up, Shelley, if you were able to find the TEPI notes, otherwise we can go ahead and skip.
I will start with an apology to Dr. Gaither. I fumbled getting the draft minutes to him. Sorry about that. At TEPI, they approved their minutes from July. We've got a vice chair role needing to be filled by one of the members. And then on their list of discretionary reports, they added in the second position a report to look at the management of patients with acute behavioral emergencies in pre-hospital areas with sedation and restraint. And that's all.
All right, thank you very much. All right, next on the discussion and action items, first on the agenda is discuss, amend, and approve MDC meeting minutes from September 16th. Those are being presented right now. As a reminder, if you can say your name when you make a motion. If I can get a motion in a second, please.
I move for approval, please. Frank Walter.
Thank you, Frank.
Second, Jason.
Thank you, Jason, for the second. All right, those are being presented. Any recommended amendments? Hearing none. Any opposed, please say nay. Hearing none. Any abstentions? All those in favor, please say aye.
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 All right, excellent. Next on the agenda, discuss, amend, and approve adding language to Table 1, EMCT drug box for limited drug box. The verbiage is on there. If I can get a motion in a second, please.
Hi, Gail. It's Amber Rice. Motion to discuss.
Thank you, Amber. Can I get a second?
Frank Walter, second.
Okay, we got a second there. So just a little bit of background. I think we had this on the last agenda, but we ran out of time. This was a request recognizing that there are many circumstances when a limited drug box may be used and approved by the agency's EMS medical director, such as wildland, tactical, bicycle teams, etc. And so the request and recommendation was to add this verbiage to essentially, we know that this is likely going on in many parts of the state when it's in these certain type of kind of austere environments, and just making it clear that if the administrative medical director approves it for these types of settings, that a limited drug box could be utilized. So that is the background. I will open it up for discussion.
So my understanding, this is Frank Walter, my understanding is there's nothing new or different in terms of the available drugs that are possible to be carried. It's just that you may have to have a much smaller package if you're on a bike, a Segway, something like that. Is that correct?
That is correct, Dr. Walter. Thank you for clarifying.
Sure. No, thanks. Sounds reasonable to me.
Gail, this is Dr. Stites. I just had a quick question.
Yes, go ahead.
Was the theory behind this so I know there's some requirements as to what make up a drug box. Was the idea with the limited drug box to be able to leave some of those items out in a smaller package like Frank was alluding to?
So I'm making sure I understand the question correctly. Essentially, the request or understanding is that certainly, like if someone is on a bicycle team or a SWAT setting, they may not have the full drug box. So it would be that their drug box in that setting was a limited component. So not necessarily just taking a few things out of the drug box to go on a call, but rather than when you're deployed in a specific setting such as these, where it's an austere environment, that you would have a limited drug box that is approved prior to deployment by your administrative medical direction. Does that answer your question, Dan?
Yes, and I was just hoping to clarify what Dr. Walter was saying. So it's not just a smaller package, it's a limited drug option package.
Correct. So we're not changing what's on the drug table itself. Essentially, it's kind of like a menu, and you would pick a smaller menu that's more specific to the setting you're working in. That might be a better way of explaining it.
Perfect. Just want to make sure I was on the same page. I have multiple teams that could use that, so wanted to make sure.
Thank you for clarifying.
Hey, Gail, this is Dan. Just a quick question. Is there a way to game this so that basically an agency or a medical director can basically say, hey, those drugs are hard to get now, so rather than going through the hoops of explaining why we're substituting a drug or whatever, or just we'd really rather have 12 medications rather than 40, etc. Is there any way to game this so that it kind of becomes, it really gets used for something other than what clearly makes perfect sense for this kind of thing? You know what I mean? Does this create an opening where it could kind of be gamed by basically approve a less robust set of drugs, etc.? You see what I mean? Is there an unintended workaround that this is creating, or is it explicit enough, do you think, so that's not possible, or at least it's not possible within the actual verbiage of it?
Yeah, thank you. I think it's always good to think about unintended consequences, which may be possible. My hope is that the language that was recommended by PMD is specific enough to preclude that, because it really limits so special EMS circumstances with very specific examples. So this should not apply to your normal unit that's in service on a typical call. This is really a very specific setting. So hopefully that verbiage would address that. Certainly, I think if an example like that came forward, we could point back to the drug table and say that this explicitly lists the circumstances where that could be utilized. Does that answer your question, Dan?
Yeah, it's just, having been around long enough, it's very interesting how some systems or medical directors may interpret oh, this is great, this opens this door. And so, yeah, I agree that the draft that I saw made it very clear, but again, clearly we don't want this to be a slippery slide that ends up with basically ad hoc drug boxes because this opened the door. So I think you're right. I think the verbiage protects that, but just trying to think of when we make decisions like this and 5 years down the road, sometimes we've been really surprised at what's happening out there.
Yes, no, thank you, Dan. I think that is really good discussion to have at this meeting, because I think sometimes when things are approved, if we don't talk through all the potential downstream effects, we sometimes don't realize what could happen. So thank you for bringing it up as a topic for conversation.
This is Frank Walter again, and thanks to Dan and Dan. The only question I have then is wildland tactical bicycle Segway makes perfect sense that you're going to need less drugs and maybe not just as smaller packages. Dan initially clarified, but fewer drugs, which is what I'd meant. The only question I have is regarding utility terrain vehicles. And I just want to understand better then why they can't take a typical drug box on a utility terrain vehicle.
Good question. I think this came up really a lot of times. Those are used in a setting where they sometimes those vehicles are used to get to a more austere environment. So they would kind of get that back into the woods or in kind of a special event and then have to get up and walk a distance. And so the concern is that they wouldn't want to leave any drugs unattended on that type of a vehicle. And so they would have a smaller component because they often utilize those vehicles to get to a more, even further austere environment.
Thank you.
by the way, that certainly is a wrinkle. Because again, I think, this committee are obviously really, really interested, very interested EMS physicians who are volunteering our time and are really active with our agencies, and we're really all in. But as you know, that is not descriptive of all, but we don't even know all of our medical directors in the state, et cetera. So as soon as you link it to some kind of vehicle, I suspect that's not a vehicle that has a universal definition that's accepted. And I wouldn't put it past some places to say, okay, we're going to identify this vehicle as one of those. I mean, again, it's just very interesting wrinkle. And like I say, my experience has really surprised me sometimes. So as you know, I wish we had a drug box of 12 drugs, but that's not the point. So I don't know if there's a way to specify that. You might add a rider, if you will, to the vehicle type, and maybe have a parenthetical off-sphere, conditions or something, right? Because you can almost designate any vehicle as a vehicle type if you want to.
So certainly the committee could vote to eliminate that last option on the line. So you could certainly vote to leave it wildland, tactical, bicycle, and Segway, period, which would then essentially eliminate that more vague verbiage and still gives you the flexibility with these other environments. So I think those are really good discussion points.
I think that's a good idea, because if I understood correctly, the utility terrain vehicle was to go somewhere wildland. And so I think it's already covered, and it might address the concern of mission creep, so to speak. So I don't know if that's open for a friendly amendment to delete the UTV and just end with Segway. Over.
Thank you. Thank you, Dr. Walter. So I hear a friendly amendment to hear and Segway, period.
Hello, this is Dr. Preston. I had to get myself off mute. We have a lot of utility kind of off-road vehicles because we do a lot of desert rescues, and there's no one needing my crews there. They are it. And so it would be nice for them to have a smaller box, because you're right, they can't take the whole box and carry it with them when they have to leave the vehicle to walk on foot to further extricate the patient. So I understand the vehicle creep, but it is actually very helpful when you've got a crew walking up mountains into the desert to extract someone and not have to carry all that with them and, risk leaving the larger box at the vehicle where something could happen to it.
This is Dr. Seitz again. I have multiple agencies that also use these, and I'm thinking more of like the golf cart size, Gaither size UTVs, not like a 4Runner. So I don't know if we could clarify it maybe and use a weight limit or something like that to exclude vehicles that we wouldn't want to use.
Yeah, we use like Razor kind of vehicles.
Sure. Huh.
Does wildland cover that for you then, though?
I don't know. It's sort of within the city limits. I don't know that it's really wildland or not.
Yeah, and mine would be Maricopa County Sheriff's as well. Sorry to jump in there. So it's kind of within our general jurisdiction. I'm not sure what we consider wildland, but definitely within our county.
So I do see TJ McKay has his hand raised. If I can just call on him.
Good morning. I'm not really sure if I'm in the right frame to mention anything, but coming from a pre-hospital perspective and running on a lot of these, it sounds like you've got a discussion on the type of vehicle. And the only suggestion I was going to make is, for example, as a tox medic, I had a very specific tox box that I could take. but it was the drug box itself that was defined and what went into it. Would it be helpful to define a special operations drug box or a special assignment drug box with ingredients that you would have in there, certain amounts of certain medications to accomplish the goal that I think that the request is for, without limiting it to a vehicle? So you could title it and you could limit the use and then define what would go into essentially that tactical drug box. Just a suggestion.
I wouldn't want to pigeonhole it, Dr. Stites, again. I wouldn't want to pigeonhole it like that, just because like my Central Arizona Mountain Rescue team would obviously need a very different drug box makeup than my SWAT teams, for instance.
Yeah, this is Dan. I totally agree with this as incredibly reasonable. So where we're headed with this, the purpose of where we're headed with this, it makes complete sense to me. I see the problem. I think that's a great suggestion. I see the problem with it as twofold. One is, in some settings, you may literally, the medical director may just want them to have 2 drugs, right? Which is perfectly reasonable in some settings that are these austere, particular incidents, or settings type of thing. So that's one problem with specifying that. It may not meet everybody's needs that we're trying to help with this. The other thing is as soon as we make a second drug box, if you will, then I'm even more concerned about the issue of that becoming the drug box for half of our vehicles in our system, because it saves money, et cetera, et cetera. So to me, it seems like we are talking about the purpose and the setting that define trouble even in the middle of Phoenix. The Phoenix Fire, has a particular part of their city where the reality is the only way to truly access it is by, I call it. But the concept clearly is that it's very specific. A place.
Sorry, Dan, we are hearing every other word under there.
Okay, sorry. Then I'll stop because I'm in the mountains myself. I'm in austere conditions myself.
Thank you. Sorry about that. All right. I see Dr. Walter has a comment, and then we'll probably need to kind of move along on the agenda. So, Dr. Walter, go ahead.
Oh, thanks for the 2 comments from the other commission members regarding the fact that wildland won't do. Would off-road teams fill the bill?
I think if we put in verbiage, this is Dr. Preston, of off-road vehicle, that would definitely distinguish it from the rest of the rescue squads and ambulances and fire vehicles.
I guess that would be a pleasant amendment to my first amendment, just as you just said, off-road teams. Thank you. Over.
All right, thank you. So, whatever final verbiage, we will make sure that legal counsel reviews it to ensure that we are not violating anything that's otherwise specified in statute and rule. So it sounds like we have an amendment to include, instead of utility terrain vehicle teams, off-road vehicle. Is that the correct verbiage?
Off-road vehicle teams, maybe?
Okay. I think the team is the key piece of it because it's not your normal response unit. All right, so we have a motion and a second with a friendly amendment. Is there anyone opposed? Please say nay. Any abstentions? All those in favor, please say aye or type it in the chat.
Aye.
Aye.
All right, that is approved. All right, next up in the agenda is to accept nominations and approve a vice chair. We have been discussing having a vice chair in the event that I would not be available to run the meeting as the chair of this committee. We have received a nomination for Dr. Gaither as a vice chair for this committee. We'll also open up to the committee if there's any other nominations from the floor. So I'll open up for other nominations first. All right, hearing no other nominations, is there anyone opposed? Please say nay. Any abstentions? All those in favor, please say aye.
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 All right. Thank you. Next on the agenda item is discuss, amend, and approve adding Ultron guided IV to scope of practice as STR for paramedics. I will give a little bit of background before we open it up to a motion. I know we just very recently completed an extensive scope of practice update and review that went through the exempt rule writing process. Shortly after that, I think a day within that getting finalized, we received feedback from multiple hospital systems with a request to add Ultron guided IV as a STR for paramedics. Many hospitals are utilizing paramedics to help augment the nursing shortage, and they felt that this was a very appropriate skill where they have good training and documentation of how they've trained paramedics on this skill set as a STR. So as part of this request was to bring this back to this committee. This is why we are kind of bringing it directly here. We did discuss this at EMS Council, but because of the shortage that's going on and staffing crisis statewide, we are trying to do an expedited recommendation if that is the committee's vote. So if I can get a motion to discuss and amend and approve this action item, please.
So moved.
So moved, Jason.
I think I heard a first and a second, I believe. Thank you.
Yeah.
All right. So I've hopefully set the stage. I will go on mute and then open it up for discussion.
So Dr. Bradley, if I can, maybe I'll start with a little background on our side. I think many of you know paramedics used to practice in our facilities under the nursing scope. And when they were doing that, we had trained our paramedics to do ultrasound guided IV placement at the Banner facilities down here in Tucson. We have published the results of that experience. I shouldn't say we, I should say our fabulous, outstanding ultrasound group studied that as a research project and has published their findings that one, paramedics can be quickly and easily trained to place ultrasound guided IVs, and two, their success rates in difficult IV patients, I should say in those patients who are difficult to place an IV in, is far superior using ultrasound guided IV than physicians or nurses in placement of those. So they are better at it than we are. They are better at it than we are without using an ultrasound. They have a higher success rate and fewer complications. So I think the medical literature certainly supports the kind of paramedic placement of ultrasound guided IV in the hospital setting. I will clearly state I'm not sure of any literature in the pre-hospital setting. So that's a little science background to it. And I will also stop talking for a minute.
Thank you, Josh.
This is Jason. You know, this is something that we recently started giving medical direction for paramedics within our hospital, and it's worked really well. And that was actually one of the first requests was, can they do ultrasound IVs so they could send them to the floor from the ER or wherever else? So I think it's a great idea. The only other question I had is this going to be just in the, where we split out the hospital-based scope of practice? Is this only going to be as far as an STR for hospital-based, or is it going to be open to all paramedics, so like flight medics and others can do it with appropriate training?
Great question, Jason. So that was something that was also brought up at EMS Council. And so very good point. We do not have a separate scope of practice. We have the separate drug table for hospital paramedics. We do not have separate scope of practice. So if this was approved as a STR, this would be then part of scope of practice for all paramedics if approved by their administrative medical direction, regardless of setting of work. So thank you for clarifying that as well.
Perfect. That's what I'd like to see.
Just a reminder, we recognize this has been a huge request from a number of stakeholders and hospital systems throughout the state of Arizona. We are trying to figure out the most expeditious way to get this potentially included. We recognize we do not currently have approval for scope of practice to be updated. We would still need to get approval if that was approved by this committee today, but we wanted to at least get the vote of the committee to try to move forward on the topic. So just wanted to at least put that out there, that a vote today would not necessarily mean that we have gotten permission to open up that rule package, even though it is part of exempt rule writing. Any further discussion on the item?
Dr. Bradley, if I could maybe add on that side, one of my concerns, and just to be clear, I don't provide medical direction for the hospital paramedics here in Southern Arizona, so I don't want to step on the great medical directors that do work with those medics. However, my concern with this path, and I think we should approve this, so I don't want to not approve this, but my concern is the time that it would take to actually put this into practice. As we know from our IM epinephrine struggle, we waited for, I believe, 2 or 3 years before our EMTs could actually administer IM epinephrine due to the need to go back to an actual rule writing session to get that added. So to that end, I understand we cannot discuss it now because it's not on the agenda, but I would like to offer up kind of the path I am interested in taking to others who may have similar interest. Kind of from an academic perspective, I'm interested in doing maybe a pilot project through the state to study the safety and efficacy of this, and also allow some of the medics that may already be trained how to do this to continue on with that practice. So I would be interested in submitting for a few facilities, the Banner facilities and any other facilities that are interested in participating with me, a pilot project to this group in the future. Obviously, I can't add it to this agenda, that would allow ED paramedics to place ultrasound-guided IVs, and then conduct a simultaneous, of course, quality improvement project to ensure that that is a safe practice. And perhaps as a pilot study, we could then report back to this group on whether or not that is safe and effective.
Gosh, I think that's a great idea, and I would love to join with you on that if it's possible.
Perfect. Anyone who would like to kind of join with me on that submission, it's going to be pretty straightforward. There are going to be a few requirements, so shoot me an email if you'd like to kind of join in that submission. I think most of you have my contact information. If not, let me know, and I'll somehow we'll get connected.
Thank you, Josh. All right. If we can, it sounds like we've got a motion and a second on the floor, so I will just reiterate and take a vote at this point unless there's any further comments. If anyone opposed to adding ultrasound-guided IV to scope of practice as STR for paramedics, please say nay. Any abstentions? All those in favor, please say aye.
Aye.
Aye. Aye.
All right, that motion is approved. Thank you very much. That was great discussion. Next on the agenda, discuss, amend, and approve adding venous blood sampling to scope of practice as STR for EMTs. If I can get a first and a second motion, please say your name first.
Josh Gaither, I can make that motion.
Thanks, Josh. Is there a second on the floor?
Jason, I'll second.
Thanks, Jason. All right. Just a little bit of background on this. Again, this was another after we finalized scope of practice. Many of the hospitals came back to us and said that they noted that we had venous blood sampling was available for AEMT and above, but not for EMTs. And while we had added the peripheral IV insertion as an option for EMTs as an STR, their concern was that the hospitals are pretty uniformly utilizing EMTs and paramedics to start IVs and draw blood, and they wanted to ensure that they were operating within scope of practice. And so the request was to see if we could add this in to cover the fact that realistically, I think in the pre-hospital setting, EMS, when they start an IV or just starting a peripheral IV, in the hospital setting, there's typically drawing blood and starting an IV simultaneously. So this was just to formally cover the fact that this is likely occurring throughout our states to ensure that those EMTs are covered under scope of practice. So that is a little bit of background on the topic. I will go on mute again and open for discussion. Thank you.
I will, sorry, Josh Gaither, I will lend support to this wholeheartedly.
Thanks for that explanation, Gail. The only question that I have is whether this would expand pre-hospital drawing of bloods for law enforcement for evidentiary driving under the influence, whether alcohol or other drugs. I don't know if that's been thought about or addressed. I'm still supportive, but again, thinking about the slippery slopes.
Great statement. That has definitely come to me occasionally as a question at the state, just even at the paramedic level. And my answer is certainly that is up to you as an agency to decide whether or not you would like your employees to participate in that. So certainly that opens that individual drawing the blood up to testifying in a courtroom. And so that would, I really think, be an agency and an operational question. But it does come up periodically, even just with the paramedic level doing blood draws.
So it would be up to the individual medical director then whether they said that's fine for our medics or EMTs to do it.
Correct.
Okay, thank you.
Any further discussion? Hearing none, I will go ahead and take a vote on the item.
Hey, Gail, this is Dan. Just a quick process question. Just a quick process question before this vote closes. Is this also encumbered by Josh's comment from the last thing that this could take years to actually take effect? I've forgotten the process and procedures of these.
Unfortunately, yes. So this is again in the under the scope of practice process. So the request and the feedback that we gave to stakeholders was that we would absolutely bring this forward to MDC to take a formal vote. And if that was approved by MDC, we would move that up to ADHS leadership. And certainly, unfortunately, at that point, it's really out of our hands. But I think a formal vote from this commission would be very helpful moving this forward. But certainly, to Josh's point, this certainly could be something that does not get updated until scope for practice gets officially opened again.
So the much bigger question then would be, is someone working on the potential of a more facile way in order to make changes like this, which clearly shouldn't need massive rules, procedures in order to change, because otherwise we're always going to be years behind the advances in practice.
I wish I had a good answer for you, Dan. This has been something for me that is, when I first started at the Bureau, had really said we need to update scope of practice. And it took almost a full 2 years. Actually, it did take a full 2 years for that to actually occur from when that request started. So right now, we do not have a more facile approach to this. Certainly, there's occasionally going to be the option for a pilot project, such as what Dr. Gaither is recommending for the ultrasound-guided IV. That and hearing the proposal will have certain mechanisms in place. This is a little bit trickier, but I think for the record, your point is very well taken.
Yeah, it just makes we're strangle. This is a stranglehold on us being able to improve outcomes of patients by clearly we have no interest in bypassing appropriate rule changes, but on the other hand, the protections against renegade changes are at every level, and so it seems to me like somebody who is expert in these arenas of rules writing and changes, it seems like we should be working on that, even if it takes a couple of years, because otherwise what we do is almost meaningless in terms of scope of practice changes, because practice may change again by the time these things come in.
Yes, absolutely. I see Brian Smith has his hand up for a question.
Yeah, I think part of the issue, since this is exempt rulemaking, is not the actual time it would take to do rule, because I've seen exempt rulemaking done in 60 days. The real issue is the rules moratorium, and that's where the problem lies, not necessarily with the way you pass exempt rulemaking.
Then as a medical director, as a medical director, I just simply want to state that this is a administrative decision that's been made at some level within the bureaucracy that is strangleholding our ability to improve patient care in EMS in Arizona. And if it would be a benefit to the director or anyone else for us to officially make that a communication to the powers that it would be important to, because frankly, this is absurd. And we're almost wasting our time.
Yes, certainly all very well taken points and shared frustrations as well with some of the processes that are in place. I think right now I saw one more hand up, I think Dan Stites, and then we'll go ahead and try to close the vote on this one.
I just wanted to say I support that thought process 1,000%.
Thank you. All right, so anyone opposed to adding venous blood draw sampling to scope of practice as a STR for EMTs, please say nay. Any abstentions? Hearing none, all those in favor, please say aye.
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 All right, that is approved. Thank you very much, everyone.
Hey, Gail.
Right.
So is this?
Yes.
So is like I said, the concern that I have dwarfs any of the other work we're doing, as far as I'm concerned. So is this going to be noted in a minute that has zero meaning? I mean, the question is there a way for us to get an official notification to those who could make changes to this or start process? Because otherwise, we're on scope of practice issues, we are wasting our time, and Arizona cannot benefit from, for instance, the studies that Josh talked about on ultrasound guided IV starts. And so I wasn't asking for okay, noted, we'll put that in the minutes. What I'm asking is what is the meaningful way to change and is there any voice that we would have as a committee to press that change? I'm not frustrated. I'm pointing out that this is absurd and it's a stranglehold.
Agreed. I'm going to hand that over to Chief Garcia.
Dr. Spate, this is Rachel. I wanted to just respond and share that as the committee votes to approve and move forward with these scope of practice changes, what we will do is we will work with administrative counsel and rules to find out how quickly we can move on exempt rulemaking, because as mentioned by others, we have seen this move quickly at times with the appropriate approvals during the rules moratorium. If there is an indication that we cannot move on something like this quickly, we will definitely be following up with the Medical Direction Commission. As you know, the department weighs what MDC recommends heavily, and we will keep in close communication with the Medical Direction Commission members on next steps and timelines for exempt rulemaking. I think that it's important that we're very clear about what that timeline looks like. And if we are not able to move quickly, I think the other alternative path here is that we can look at this pilot project as mentioned.
Thank you, Rachel. And yeah, it's important for everyone in the Bureau to understand. I see us as in this together. I can imagine, since you live with this kind of thing all the time, the frustrations are probably really consequential. So I have, what my question is, how can we be helpful? And that sounds great to me. I know the last thing you guys want to be doing is doing all this incredible work to try to improve outcomes and patient care, only for it to be bogged down in procedure. So I'm on your side. So thank you for that. That's really helpful.
Thank you. We appreciate your comments, and we will be in close communication on these.
Thank you. Really good discussion. I think these are, the role of this commission is to really help guide the state of EMS within Arizona, and these are all governor-appointed positions. So I think your statements and views are really vital to the discussion today. So thank you again. Next on the agenda item, we have discuss, amended, and approved draft drug profiles for Table 2, agents eligible for administration during a hazardous material incident, propranolol, methylene blue, sodium nitrite, sodium thiosulfate, atropine, and pralidoxime, sodium nitrite, and sodium thiosulfate. That is a lot. So if I can get a first and a second to discuss and amend and approve, please.
So moved. Frank?
This is Amber.
Thank you. All right, we have a first and a second. And I will go ahead and say that this was approved through PMD. We had a subgroup that had worked on these with Dr. O'Connor, one of the toxicologists who actively participated in this as well. And these were approved at PMD, and we are now moving these forward to MDC. And we welcome any review and input from this commission, especially the first who made the motion, Dr. Walter. We appreciate your expertise on these. So I will go ahead and go on mute and open up for discussion.
They look good. Regarding the sodium thiosulfate, and maybe it can just be addressed with education, but since almost all patients that get this gag and almost all have emesis, if they're not able to protect their airway, they maybe need intubation beforehand or administration of antiemetic beforehand.
Do you recommend, and we actually, we did have a lot of discussion in making these. We started putting in educational items and then went back and forth of how much do we put in from an educational perspective. I know, Amber, you were actively involved in these as well. If you wanted to speak up regarding some of the conversation we had about how in-depth to get educational in the drug profiles themselves.
Yeah, I think we tried to keep the style similar to the other drug profiles and not put a terrible amount of education in them. A lot of the discussion we had about these specifically were the fact that these drugs are given by fairly specialized teams who do a lot of training in this area. So they're not drugs that are administered by like the general paramedic, because this isn't all typically covered in paramedic school. So many of these individuals would be taking a Toxmedic course or be doing ongoing education for these drugs on like an annual basis, or at least on a regular basis. So that was the conversation we had, and why the group had elected not to put a lot of educational materials in here.
That sounds good, Amber. I'm comfortable with that. Thank you. And I also put in the chat too some upcoming advanced hazmat life support courses also that address all those training issues. So thank you. They look good. Well done.
Thank you for that feedback. I know there was a lot of work put in by the subcommittee from PMD prior to that meeting, and a lot of discussion at PMD as well. So thank you to everyone who participated in those and the process of writing those. Is there any further discussion or amendments recommended to the drug profiles? Hearing none, anyone opposed, please say nay. Any abstentions? All those in favor, please say aye.
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 All right, excellent. That is a record timing for those. I am very impressed with all the work that was put in by that work group on that. So thank you everyone who participated once again. Next on the agenda is discuss and amend approved draft T3Gs for hydrocarbon poisoning and methemoglobin toxicity. Again, just for discussion as a kind of background, these were identified as not being in our current T3Gs with reference to medications that we had in the drug box, and so these were put forward again by the same subcommittee that had worked on the drug profiles and then approved by PMD with input from Dr. O'Connor. Can I get a motion and a second, please?
So moved. Frank.
One second.
Thank you. Got a first and a second. I will go on mute and open up for discussion.
Gail, this is Amber. Just again, for everyone who's looking through these now, these were written similarly with the drug profiles, with the fact that these would be given by a Toxmedic. So keeping that in mind with things that may or may not be on here, they're not really designed for sort of the general field paramedic, but for a Toxmedic to be given.
Okay. Thank you, Amber.
And just a clarification for me, Amber, down at the bottom, as we look at the screen, on the left is the adult dosing and on the right is the pediatric. And I see the pediatric's got that little bear. Would it be helpful and to say adult and pediatric in that? Or they all look like this and everybody's used to looking at them like this?
Yeah, we kept the formatting identical to all of the other T3Gs, but if there were specific issues with this, we can, discuss the formatting when we reviewed the T3Gs in, sort of the upcoming months.
Okay, that's fine. As long as people are used to looking at it, that's fine. I would just, obviously it's a big dosing difference, so I just wanted it to be very clear. Thank you.
And we will make sure, I do see that we'll expand that so the bear is not overlying any of the pediatric dosing side. So we'll do a little formatting changes there. Any further discussion? Hearing none, is there anyone opposed to approving the draft hydrocarbon and methemoglobin toxicity T3Gs as presented, please say nay. Hearing none, any abstentions? Hearing none, all those approved, please say aye.
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 Excellent. All right. Thank you, everyone. Last on the agenda, this was a proposal from the subcommittee to PMD, who is moving it forward to MDC for consideration, which is to discuss, amend, and approve updates to Table 2, agents eligible for administration during a hazardous material incident, with the recommendation to remove any medications that are currently on Table 1. So that was why what the discussion was: if it's already on Table 1, does it need to be listed specifically on Table 2, with the recommendation to remove those. So that is the background on that. We have a clean and draft version available for review as well. If I can get a motion and a second, please.
So moved, Frank.
Thank you. Is there a second?
This is Amber, I'll second.
Thank you, Amber. All right. So I will go ahead again and go on mute and open it up for discussion.
Just a question for clarification. Aren't we giving 50% dextrose for non-hazmat care, just for regular hypoglycemia?
Most agencies have switched to D10 for treatment of hypoglycemia. And I believe that the dextrose on Table 1 is listed as a quantity as opposed to a concentration. But if there was a specific reason in the hazmat setting that you felt that D50 was necessary, that could certainly be considered as part of the table update.
Okay, I'm seeing the D50 in the hazmat, so I'd say, leave it there. That's fine. But I'm just surprised that it wasn't already covered in general medical care, and that it was needed specifically here. Have we eliminated D50 then from the regular paramedic administration table, even though most are carrying D10?
That the way it's worded is simply dextrose. Let me see if I can pull it up and I can share that here. Just give me 1 second. It's really just a quantity of dextrose as opposed to the formula. It looks like Shelley is beating me to the punch. Thank you, Shelley. So it might need it to be a tad bit larger there. So if you can see here we have dextrose, and it's listed as 50 grams. So it's kind of the amount versus the concentration, if that answers the question.
Okay, thanks for clarifying that for me.
Thank you. And I saw Brian, I believe you had your hand up as well.
No, I was just going to reference that also. So I took my hand back down.
Thank you, Brian. So this, what's currently being projected on the screen, the quote-unquote clean version, would be what Table 2 would be updated. Certainly that would, reference people. I think the other medications, many of them are optional and will continue to be optional on Table 1. But over the years, as the drug box has kind of evolved, many of the medications that were historically on Table 2 have moved to Table 1. So this list would really be the kind of quote-unquote hazardous material or tox medic drug box that's very specific for that group. Any further discussion? All right, hearing no further discussion. Anyone opposed to the update to Table 2, agent eligible for administration during hazardous material incident, please say nay. Hearing none, any abstentions? Hearing none, all those in favor, please say aye.
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 All right. Thank you, everyone. That was quite a bit of material we covered. I'm very impressed. All right, next is agenda items to be considered for the next meeting. You can forward those to either Shelley or myself. Under call to the public, I just wanted to let this commission know that we likely will be bringing together a special session to discuss potential pilot project propositions along with surge plan and scope of practice. We will make sure that we stick to all rule requirements regarding ample notice, which I believe will be at least 14 days. But please note that we likely will have a special session coming up sometime within the next month, so be on the lookout for that. Is there anything else on the call to the public? Hearing none, there is a summary of current events on the agenda packet, and Dr. Walter also put in the chat as well as some upcoming training for advanced hazmat life support. Our next meeting will be May 19th, 2022. Location to be determined if we will be completely virtual or hybrid. We will make sure we give people ample time to be aware of that ahead of time. A big thank you to everyone. We had a very hefty agenda packet today, and clearly people spent a lot of time reviewing ahead of time before the meeting, which makes it much more efficient. Really good discussion topics, and I appreciate everyone's input today. I think it's vital for EMS across the state of Arizona. So again, thank you to everyone, and we will go ahead and adjourn at 13:12. Thank you.